Um, just as a couple of, I'm going to talk about healthcare, but a couple of other areas, significant, the large areas of the economy where PE is actually playing a big role is real estate, and also now in sports. Um, how many of you know that the Miami Dolphins, a local team here, professional team, is actually in advanced talks to sell 10% of their equity in the Dolphins will be owned by this PE firm called ARush Management that is run by Joe Tsai, who happens to own three or four other professional sports teams, including the Brooklyn Nets. For those of you who are into sports, the NFL was the last professional league that hadn't yet sold out to PE firms. MLB, NHL, NBA, all of them to varying extents, actually their teams are owned by, or at least partly owned by PE firms. The NFL was the last holdout, but they've since, I think, a few months ago, they changed their policies where a PE firm can acquire up to 10% of a team, but they don't get any voting rights. How many of you have kids in college? Not yet, no. Soon, yeah. So I had, my daughter just graduated last year, and I have a son in college, and so I know what it is like to pay their rental bills each month. And even in college towns, or even Austin, I don't consider Austin to be a college town anymore, but in a lot of college communities, PE firms like Blackstone and others, right, they have completely changed the rental landscape. I'm not sure if it's true here in Miami, but it used to be that when I was a student, for instance, most of the apartment buildings in Austin then were owned by, typically one or two owners. In my case, I had a small apartment, a studio in a small building which had maybe 15 units, 15 apartments, and the owner was a dentist. So the guy had basically, over time he had accumulated enough money to buy a small apartment building, and he would rent it out to students. Today you go around Austin and just the landscape is completely changed. You see these huge, swanky towers, like 20, 25-story towers. They look like five-star hotels. Um, and, well, that's a different story. College kids living in the luxurious amenities. And the rents have just gone up like crazy. It is just nuts in terms of. So basically, what the PE firms are doing are they're either renovating existing apartments or building new ones, and because it is a supply demand, there is still a huge supply demand imbalance, especially near college campuses. They know they can charge astronomical rents, and they've just completely transformed the market. So two different markets I'm talking about, the sports as well as the rental market is, just, PE firms have taken over these markets to a large degree, right? And so you'll find that there are very few of these independent mom and pop type owners anymore around the UT Austin campus at least. And I visited ASU, right? Tempe, was it about a year and a half ago? Um, and Tucson as well. And I found the same thing. I mean, there's these like luxurious amenities, but the rents are just crazily high. I can't imagine a one bedroom in the Tempe area going for $1,500 a month. Right? I mean, and that is on the low end. So this kind of motivated my yes, yeah.
No, good question. So the two examples you give, they are those for-profit businesses, right? The NFL and the other real estate example.
Yeah.
So for the healthcare, I don't know much about it, the PE side, but in healthcare, uh, aren't those most of the healthcare organizations, non-profit organizations? Or are you looking at those for-profit?
No, we are actually, so it's very interesting. You'd think that, by if you didn't really study the industry, you'd think that would be the case. Yes, the healthcare industry does have a large percentage of non-profit hospitals, but among the for-profit ones, in fact, I think I have a slide here. 22% of all for-profit hospitals in the US are owned or partially owned by PE firms. And 8%, so if you look at across the board, including for-profits and non-profits, etc., it accounts for 8% of the hospitals. So it's still a sizable number. Interestingly enough, Duke, right, Duke hospital system or the Duke health system, Duke University's health system, is partially owned by a PE firm.
Oh.
And you would think that Duke, being a private university, wouldn't sell out to a PE firm, but they do. Right?
So there's no law against it.
Yeah, there's no law against it. I don't know what would happen if it was a state institution, like for UT health system, UT's medical school. I would imagine that they would have to go get approval from the Board of Regents or something like that. But I don't know what the legal implications of that would be.
Some of them are probably listed by the stock hospital systems.
Is the debt you mentioned the debt of the initial partners of the private equity firm? Is that the debt they bring to the company? Or?
Well, no, the debt is part of the acquisition cost. So they don't put in all of the money to acquire the company. So they basically, take out debt, right, to acquire the target, and then the target gets saddled with the target company gets saddled with that acquisition debt.
Is the debt, but the debt is to partners, like when Warburg or whatever, they have funding rounds. Are the debtors, are those the creditors to which they have the debt? Those that participate in the funding rounds?
No, that's what I was saying.
Okay.
They attribute the debt to the acquired company. So the acquired company gets kind of saddled with the debt. So let's say so the Carlyle Group is the biggest PE firm in healthcare, right? And many of you might have heard of Carlyle Group, right? So it's not as if the Carlyle Group partners get saddled with the debt. They take out part portion of the debt. Let's say if they acquire a health system for $1 billion, they might pay for $300 million. They might pay from the funds that they raise, right? And typically, the funds that they raise would come from institutional investors like pension funds and so on, right? So they take that money and they use that a portion of that money to buy the target firm, but the remaining $700 million is debt. And who gets the debt? It's not the partners of Carlyle, but it's the people who are the hospital or health system gets saddled with this. Just gonna get a bottle of water from my bag. So this kind of led us to study. So this, there's been, if you look at the literature on private equity in healthcare, there has already been quite a bit of work that has been done in this space. Everything from the top clinical journals, medical journals such as JAMA and New England Journal of Medicine. There has been some work that has looked at the impact of PE ownership in hospitals and how that has actually impacted the quality of healthcare that these hospitals are providing. And so that kind of motivated us to look at this problem a little bit differently. And we feel, and again, based on the results that I'm about to show you, we think that the story is not completely one-sided, as the literature indicates it to be. And so rather the impact is nuanced, right? So the findings of our study would say that it really depends, right? What you're looking at, and perhaps in some cases, PE could even have a beneficial impact on healthcare value. And through our analysis, through our empirical analysis, we show you under sort of what conditions PE could actually food value. Um, so if you look at the PE sector, the healthcare sector, and you look at PE investment, if you look at the deal values here, the pointer isn't working, but if you generally look at the deal values, you can see just it's like a linearly growing trend. Again, in this particular case, this is data from PitchBook, which tracks these deal values. I think in the case of 2020, it was a little bit of an anomaly because of COVID. But generally speaking, you can see that the deal values have gone up from 22 billion to 151 billion in 2021. So it has been like a huge growth, and it keeps climbing every year. And if you look at again these numbers, the investment in trends in healthcare, you can see how the first few years, for instance, from 2010 to about 2014, it was relatively flat. But in terms of this is again ownership of hospitals, it has climbed steadily, where you can see that out of all buyouts in healthcare, in 2020 it was about 18% of all buyouts. So there's been a lot of stories in the press. You look at many of the reports that have been coming out in terms of quality issues, right? So, for instance, there was this famous case of a hospital in Boston that was acquired by a PE firm, and there was a pregnant a woman who was pregnant who went to deliver her baby in the hospital, and there was a particular item that the doctor had prescribed for her. It was, it wasn't a procedure, but it was some specific.
Okay.
It was.
No,
it
I'm
was some
listening
sort
to
of
a seminar, but I have myself on mute.
device that you need as
Is
part
there
of a
some?
complicated pregnancy, and since the hospital had been acquired by
Yeah.
a couple of years before that,
What did they?
were just,
I don't even look at it. So
slashing
what is
costs
it?
significantly, and they didn't have that device, right? And basically, she actually ended up, dying because of the lack of that particular, device. And there was a big lawsuit from her family. It came out in the press, and so there's been a lot of negative, reports about PE firms. And basically the whole idea is that if you want to make money and you want to have an exit within 3 to 5 years, what are you going to do, right? You're going to slash costs. You're going to perhaps even slash service lines, right? Maybe remove unprofitable service lines, right? And so that might have profound impact on the broader community, because in a city like Miami, large city, you typically have the choice. If one hospital shuts down, you have the choice to go to another hospital, right? But in many communities, especially that are out there in the suburbs or even in rural areas, there might just be one hospital in town. And if that hospital shuts down or closes down certain unprofitable service lines, then you will have to drive perhaps several hundred miles to get that healthcare that you need, right? So there's a recent bill in California that would require state review of PE deals in healthcare. So before a deal can close, the state would actually have to review the deal to make sure that that it wouldn't hurt the community. Federal agencies are now seeking public input on how buyout deals affect medical care and costs. And this was the article that I mentioned about, they talked about different anecdotal reports, one of them being the pregnant woman in Boston, So in terms of anecdotal evidence and evidence from what we call not large empirical studies, but relatively like some of them these are anecdotal evidence, some of them are based on relatively small sample studies. There's been mixed evidence regarding the impact of PE in healthcare. There have been some studies that have shown a beneficial impact. So you get a much needed capital in cash-strapped hospitals. And by the way, I'm using hospitals as my setting, my unit of analysis because it's easier to get data at the hospital level, and hospitals tend to be big. They tend to be, they have to, go through public reporting requirements. If a hospital is, even if they have one Medicare patient in the entire hospital, you have to report it to the regulatory agencies. But a lot of the impact of PE is also being felt outside the hospital sector. So if you have surgeons, right, you have a group practice of surgeons who are running an ambulatory surgery center, what we call ASCs in the literature. These are hugely profitable, profitable, practices, and PE firms come out. If let's say three of you are surgeons here, the PE firm will come and say, okay, we are buying out your share of the practice. We are going to give you a big fat check initially, right? Maybe a couple of $1 million, $2-3 million to buy out your share of the practice. In return, you're going to work as an employee, right? And we are going to, give you some sort of like a market salary as an employee, which is obviously going to be far less than what you're taking home. When you divide up the profits, at the end of the year, how much ever you're taking home, we're not going to pay you that, but we're going to pay you a base salary, and we're going to pay you some bonus based on your productivity, how many surgeries you do, how profitably you deliver those services, and so on. So in a sense, they're giving you a big cash infusion at the very beginning, especially which could help cash-strapped operations, but it's also an incentive for the surgeons to sell out, and in return, you become an employee, and you deliver to us, like a profitable, business where we get to keep a portion of the profits, and you might also share in some of the profits. So that's how they work in many of these, cases, especially with ambulatory surgery centers.
How many of these buyouts would have gone bankrupt if the buyout hadn't taken place? I'm thinking about this counterfactual. That's your first. Did they really need the capital in the sense that they were going to close down anyway?
I don't have the answer to that, and that would be hard to tease out based on the data. I mean, you'd have to look at essentially firms just like that, the target firm, and see, or hospital, and see, if two firms, one of which was bought out by PE, if they managed to, stay afloat. Well, the one, I mean, it's an interesting exercise, but
the counterfactual.
Correct.
So that's never.
Yeah. It's
never easy.
not easy to observe given a lot of other trends. Like, so for instance, if the year after somebody was bought out, what if suddenly insurance and Medicare decides to increase the reimbursement rates? So now suddenly, what was previously unprofitable could become a profitable line of service. So do you attribute it to the PE firm, or do you attribute it to higher reimbursement rates? Right? So there's a lot of exogenous factors also that are happening. Yeah.
So if you look at prior literature, this nonprofit versus for-profit hospitals, you typically find that there's virtually no difference between nonprofit hospitals and for-profit hospitals. So if you look at papers and look at upcoding and cherry-picking behaviors, quality of outcomes, you typically find that nonprofit hospitals operate very similar to how a for-profit hospital operates. So is your paper sort of implying that there's a difference between a hospital that is operating as a for-profit organization versus the private equity firms having this organization? Like, is there a difference between that?
We don't look at that particular issue specifically. And I would say that, so we do control for the the profit status, right, of the hospitals in our data set. But I think, I would probably push back against the characterization that there are no differences between for-profit and non-profit hospitals. Um, I would say that the for-profit hospitals, just based on their charter, right, they, you know, they, they operate very differently than non-profit hospitals. Um, like, for instance, both my kids were delivered in non-profit hospitals, and I could see firsthand that, they are, in many cases, so for instance, Presbyterian Hospital in Dallas is a non-profit hospital, and their charter, because, very long ago they were sort of founded by the Presbyterian Church, they still have many of those, um, I would say, the motto is, you know, you know, access to care is an important goal for them. You can't deprive somebody from access to care and so on.
So if I could push back on that, I think that's what we want to believe. Right, so I can, there are many hospitals that have the name Presbyterian or Saint, whatever, that are for-profit hospitals.
Sure.
All of the for-profit hospitals would have all of these conditions for access to care, for a high quality of care. But if you go on to, any hospital's website, it's essentially indistinguishable that whether this hospital is a for-profit or it's not. I mean, we can talk about this offline, but I'm very interested. I have some work in this area. And basically, any sort of recent, rigorous studies that look at the difference between nonprofit and for-profit.
In terms of what? Quality?
Quality, their behaviors, when there are certain incentive schemes, how they respond to these incentive schemes, so changes in MSTRG coding, how they respond to that. Government hospitals tend to be very, very different.
Yeah.
But typically, people find that nonprofit, non-teaching nonprofit hospitals are very similar to for-profit hospitals.
John, quick question. So if you take hospital fixed effect, how to differentiate them? Do they change over time?
So I don't know if they have never specific papers, but ownership changes do happen. So there are papers that look at ownership that do studies based on this ownership change. So I mean, if that's sort of what this paper is doing in terms of there's a sort of increase in equity, private equity coming in, maybe sort of you're measuring that effect.
Yeah, I mean, that's exactly what we're doing. I mean, we track across 13 years, we track, when a firm was being bought over by a PE firm, or when there was actually some change in ownership. The PE firm may not buy 100% of the target hospital, but they might have a sizable equity there, right? So we do track that, and we actually compare, sort of that treatment group to a control group, right? With similar characteristics, right? So to your point, one of the matching criteria would be, between the control and treatment groups would be the ownership status. So in terms of beneficial impacts, there have been some studies that have shown the infusion of much needed capital. It's good. If you're cash strapped in certain hospitals, that PE firm brings additional money to help with your operations. There's more direct managerial oversight, so you run it as a business, right? And you reduce operating inefficiencies. So that is what PE firms are best at doing. But there's also a ton of negative impacts, including prioritizing profits against patient outcomes, right? Cutting the less profitable service lines, perhaps even cherry picking patients, and hospitals being saddled with a ton of debt, right? Crushing debt. And by the way, there has been quite a bit of press reports, even in Florida, about this happening, right? Given that a large portion of the population here is senior citizens, that has been a big concern. The FTC and DOJ, Department of Justice, are looking into this, right? I mean, as they should, because healthcare is a public good, and there are rightful policy concerns. Because if you just think about it today, Medicare accounts for almost 50% of all healthcare spending in the United States, right? So they are very, very concerned about PE firms prioritizing short-term profits over patient well-being. also been some, if you look at the academic literature, there have been some mixed findings. So there have been some studies, I've listed them here, where they found that care quality improved, and other studies that have found that care quality actually declined, right? And so what we have observed based on our review of the literature is that the impact of PE is indeed multifaceted, which means that improvements in one area could actually lead to trade-offs in other areas, right? So, for instance, in some cases, for instance, this HBR article, actually shows what happens, when PE firms buy hospitals. For those of you who are interested in the managerial spin on this entire, issue, this is a very, very useful article that talks about how exactly PE is changing the healthcare sector. How, talked about questions about debt and so on. It's a great, article that actually talks about the inner workings of the PE firms. And I'm not a finance expert by any chance, so happy to sort of find out more about how they actually work from a finance perspective. So the key issue here is that there could be trade-offs between efficiency on one hand and quality on the other, right? And one of the ways we make a contribution, we believe, in this particular study is to come up with a holistic measure of care delivery in terms of not looking just at efficiency or quality separately, but we look at it from the perspective of value, right? So if you think about value being a multidimensional ratio, right? A multidimensional ratio, it's like a vector of outcomes divided by a vector of input resources, right? And these vectors consist of different kinds of outputs and different types of inputs that are measured on very different scales, right? So Michael Porter's article in I think this was at least 10 years ago, which talked about what is healthcare value. This came out in New England Journal of Medicine. It was a very short paper. He actually described he proposed this notion of value, but from a very conceptual perspective. He didn't really, define it from a mathematical standpoint, right? And one of the things I want to do in this study is to quantify value. And I've done that in a couple of prior, ISR papers looking at value among hospitals and value among ACOs. We use this non-parametric method called data envelopment analysis that we're going to use to measure value in the context of PE.
If I may ask,
Yeah.
So what I guess you would expect efficiency when it necessarily leads to decline of quality, right? So to me, it seems like they should go hand in hand, the efficiency and the quality side. So earlier you were sort of presenting evidence you could have enhancement in efficiency, but the quality of care could go down. But I'm just like from the back of my head, they should go hand in hand. When the efficiency
No, because what I'm saying is that let's say if we have 20 people in one department, right? And now I come in as a PE firm, I say, I'm going to cut half the staff. So I only have 10 people doing the job of what 20 people were doing before, right? Right? Now you're working double the time, right? And you're probably going to make mistakes, right? Which are going to be translating into, poorer outcomes, because now maybe the waiting time, like one of the things we do measure is patient satisfaction, right? So patients are, not happy because now they have to wait longer to see the doctor, because now I only have 10 doctors instead of 10.
one angle I find particularly interesting is I think you're talking about you may be cutting off those inefficient services, right? But you're creating inequity issues for society in some sense. I find that angle pretty interesting. But
Yeah.
I see you have this DEA, the efficiency analysis.
It's funny you mentioned that. I was just actually talking to a medical student So I teach this very unique course where it's called Digital Health Innovation. But so we have half the class who are MBAs, who are interested in careers in healthcare, and the other half are our medical school students who we have this unique program where they can get their MD and MBA degree together in 4 years. Right? So this is just a little bit of a tangent, but the way we worked out the deal with the medical school is that in the third year of their med school education, they take that 1 year off, and they basically they take 2 years of MBA education in 1 year, right? So they're on an accelerated path, and they complete their entire MBA curriculum. And by the way, on the side, they're not doing any med school courses, but they're still involved in their clinical rotations. So I have this course where I'm teaching this combined MBA and MBA students, and one of the projects, so they're required to do a project, and one of the projects that this girl mentioned that she was interested in is looking at the impact of PE on some of these inequity-related issues, right? Disparities and inequity. So funny you mentioned that. So I'm hoping to work with her using this data.
Can I ask a question? Do you hear me?
Yes.
Yes, hi. Very interesting. I'm Sarah Rushanek. I think when you're talking about efficiencies, you can think about that example of you have a 20 doctor staff and you're going to cut them down to 10 and there's a longer waiting line. You can flip that efficiencies, and a lot of healthcare now is incorporating AI. So you basically, even like the Epic system and others, for instance, you're busy, the doctor's busy what? His back is to the patient and he's busy filling out the forms and scribing. So this way you can do a lot of AI. It can be more efficient. They can actually see the patient. So you can think about what that efficiency is. It's not just cutting, but being more productive. So I think that that's an important, I think that whole AI in healthcare, that is basically low-hanging fruit that you can deal with. So that's my comment. I wanted to know if you thought about it.
Completely agree, Sarah. I think, physician documentation is a huge burden. Takes on average about 2 hours per day for physicians to document in the charts, and if they don't document, they don't get paid, right? So it's
right.
It's a very mundane task for them, right? But they have to do it, and there are companies that have actually developed software that can do what they call these auto coding. Absolutely, and in fact, I'm working with one of these companies in town. It's a software company that is actually developing using AI to do better job of coding. And guess what? Last year, they sold 49% of the stake in that software company to a PE firm.
Yeah.
No, but I agree with you in principle that that could be another area of study to look at what has been the impact of AI on some of these specific processes like clinical documentation, and does that improve the efficiency? But it's somewhat different from the question that we are...
Right, but you can see it. You can see it even in pathology or something where you have the AI, or radiology, you have the AI then being a partner and basically alerting, for instance, that you can see. I'm working with the pathology department here in the medical school where they, in making mistakes, they're able to use thinking about AI that can alert them. So just think about the cost of lawsuits and the cost of telling someone they have cancer, they don't have cancer, when there are mistakes there. So you can think about it not only in documentation, but in aid.
Yes.
You might have flip the questions too. Like, when you have more PE in your state, perhaps your AI adoption will be faster too.
Absolutely. And so sort of that's the second part of the story that I don't want to let the cat out of the bag, but that's kind of the second part of our story. So the first part of our story is about how PE impacts care value. The second part of the story is, can IT track whether, what portion of the IT spending is AI related, but we look at IT spending as a whole, and specifically we look at IT enabled information sharing, and can that mitigate some of these negative consequences? That's kind of the second part of the story. But thank you for the question. I appreciate it.
Sometimes the time is blinking on the screen. Does it work, the clicker?
So what is healthcare value, right? So this is going back to Michael Porter's notion of healthcare value, which was very conceptual. It seeks to optimize patient outcomes. So think about patient outcomes as a multidimensional vector of different types of outputs you're trying to track, right? So you could look at typical indicators of patient outcomes would be mortality rate, right? Readmission rates, patient satisfaction, and so on, right? And then, so you're trying to optimize those patient outcomes while minimizing your resource expenditure. So think about it as a ratio of outputs to your resource utilization, which is the denominator, right? And the higher the ratio, the higher your outcomes, and the lower your inputs utilized, the greater will be your value, right? That's what you want to ultimately achieve as a business, right? So so this notion of healthcare value, it highlights the need to balance some of these multiple interrelated but potentially conflicting objectives, right? So basically, I love utilizing this ratio again, even in my class when I'm talking about health innovation. So think about this as a ratio of outcomes to resources utilized. Right now, it is not as simple as it looks because each of these, the numerator and the denominator, is really a multidimensional vector.
A quick clarification question. For the value, we know in marketing to define value as a perceived utility divided by price. In this equation, where does the financial cost come into play?
Yeah, good question. So I think here, um, um, so the inputs, right, really are a measure of your costs that are expended to produce those services. So, for instance, capital expenses, operating expenses, labor costs, all of those are part of your inputs, right, your denominator. Um, we haven't, we purposely haven't looked at profits per se in the outcome. So if we were only looking at for-profit firms, we may be able to look at the profit margin and the numerator. But given that we have a mix of for-profit and non-profit, right? I think it would be, it would be hard for us to look at just the profit margin as a numerator, right? Because the non-profit firms, they say that look, that is not our goal. In fact, the way they work, these non-profit firms work, is that whatever margin they have at the end of the year, they, in most cases, they basically funnel it back into the business instead of, giving it out to their shareholders, right? So, and that was so. If I was doing this study with the much smaller subset of only for-profit hospitals, I would probably look at the margin as well as one of the outcomes. But in this particular study, now, by the way, this is a relatively small, I shouldn't say small, but in terms of the number of PE deals in healthcare, it's quite limited, right? So it's not like we have thousands and thousands of observations. So, I'm afraid that if we restrict ourselves to an even smaller subset of hospitals, we might actually run into the small sample, problem. Right? So for now, we've kind of ignored that particular dimension. We do have costs in our denominator, but we don't look at the profit margin in the numerator. So what we have found is that in terms of the research gap, there are two research gaps, right? So I've walked you through the literature and what others investment and healthcare value, right? Does IT moderate that relationship, right? If so, how? Is it positive? Is it negative, right? There have been some studies, and that who provided one of my studies, President's study, but there have been other studies that have looked at IT-enabled information sharing has some beneficial impacts in terms of, for instance, if you're able to, if I'm a patient and I have my X-rays or CT scans done at one hospital in, let's say, in the recent, say last 1 month, right? Why? And then I go to another hospital. Why does that hospital need to repeat that test, that imaging test, right? If there is a way for the two hospitals to share this information, to connect their systems so that they can share this information, then the doctor in hospital B can basically pull up the CT scan results from my test in hospital A, and they'll be able to see it, and so then they don't have to repeat that test, right? So in this paper in 2017 with Seskin and Eric Zhang, we actually found that IT-enabled information sharing actually reduces redundant, medical procedures. And Liam, your work with HealthyLink as well has found some of the beneficial impacts of health information exchanges in patient care. And it has been also found to reduce length of stay and decrease the admission rates, right? One of the things we want to know is, does this information sharing have any impact in the context of PE? Are PE firms more likely, like so for instance, I think Kevin, you mentioned efficiency. Are they more likely to invest in these IT systems to actually make things more efficient so that those tests are not repeated, right? And that is sort of the second part, of our study. How much time do you have? So 9 minutes total. Well, yeah, maybe I guess 19 to total, yeah. So I have 40 minutes. So the two questions are what is the impact of PE investments on healthcare value, right? Value being this multidimensional measure of outputs or outcomes realized based on resources spent, and what is the role of interorganizational health information sharing on the impact of PE investments on healthcare, right? So the key aspect here is interorganization. Within the organization, like let's say you're sharing information between departments, that is a no-brainer, right? You want to do that through integrated information systems, but it's this sharing of information across hospitals and even between hospitals and ambulatory care providers. And we show you how these two different kinds of information sharing, what impact it has. So a couple of propositions here. P can create value by enhancing operational efficiency and reducing costs. And the cost-cutting measures could have an negative impact on patient care because it results in a decrease in provider staffing, lower provider skill mix, which ultimately might lead to declines in patient satisfaction and increased mortality rates. And similarly, with respect to the propositions, you could look at the beneficial impacts of health information sharing, reducing costs, and also improving care quality by providing timely access to patient health information, which allows clinicians to better diagnose patients, right, which makes their job a lot easier, so it does improve care coordination and quality. So let's get into the fun part of this study, which is in the empirical part, right? So in terms of the research setting, we focus on the hospitals as our unit of analysis. Why? In some sense, because it is also easier to get data on hospitals because they are publicly regulated, and so you have data, for instance, we use data from different sources. The SJC Platinum database, for those of you who haven't used it, this is very commonly used by finance folks. It tracks PE deals, including leverage buyouts and all kinds of M&A types of deals as well, right? And then we use data from the CMS cost reports to look at things like labor cost and resource utilization, so on. And then we also looked at the AHA IT supplement database, which was the American Hospital Association's IT database that looks at IT use in these hospitals in our study. Right? So we combined multiple data sources to construct a panel data of 428 hospitals in the US from 2008 to 2020, which all of these hospitals saw some sort of a PE investment during this 13-year span. Right? So again, we are not talking a whole lot in terms of numbers, but this is the nature of the industry. How many of you are familiar with this technique called DEA? Okay. Oh, Kevin. All right. So I'll just I'll talk about DEA in the next couple of slides, but it's an optimization method that has been around for now almost about 45 years or so. It was developed in the late 1970s to measure, so DEA was basically initially proposed to measure efficiency of organizations, especially when the inputs and outputs are multidimensional, right? When not everything can be boiled down to a single number, right? If you can boil down all of your outputs and inputs into a single dollar value, then it becomes a very trivial problem because you just look at a single ratio. But when you have multiple vectors of inputs and outputs, each of which have a very different dimension of being measured, it is hard to do that, and that's where DEA was initially proposed to look at student achievement in schools, for instance, right? As part of the federal school, federal government subsidizes education in this country, and they were looking at how to distribute some of that money in the context of student achievement among schools, right? And it's been now widely used in a variety of practically most industry sectors. So it uses linear programming techniques to identify the optimal use of resources of using input resources to produce outputs. In this particular study, we use three types of inputs, which is our measure of resource utilization. We look at the dollar value of operating expenses, capital expenses, and labor costs. And here, by the way, this is not dollar number, but just we look at the total number of physicians, nurses, and other clinicians. So this is an actual count of the staff. And then, in terms of outputs, we look at mortality rates, the 30-day readmission rates, and patient experiential quality, which is a measure of patient satisfaction. And so the care value variable is a continuous variable ranging from 0 to 1, where a higher value indicates greater healthcare value available. So this is, this is my one, slide on DEA, and this is kind of, how it works. DMU means a decision-making unit. In the context of our study, a decision-making unit is a hospital. It could be an organization. It could be even departments within organizations, right? So each DMU, right, it takes basically, if you think about resources, right, resource type 1, 2, 3, and so on, and it produces certain outputs, right? And so there's a production function where they're converting resources into outputs, right? So each DMU or each hospital has its own sort of production function, which is using to convert those inputs to outputs, right? And so it provides a multidimensional measure of production capability, where if you look at If you think about this particular context here, let's say if you have one input and one output, and if this is your production frontier, right, and each of these are these DMUs, right, so these could be hospitals, you can see, well, if you just compare, and since the clicker doesn't seem to be working, I'm just going to show my finger here, right, so if you look at this, if you look at this axis, and you look at these 2 points, this point here dominates this point because for the same level of input they're producing higher output, right? So output is on this axis, so their output dominates this particular DMU for the same level of inputs, right? And so this is the production frontier. So the way DEA would work is that any of these inputs here, any of these DMUs here are inefficient compared to a DMU on the frontier, right? Because the frontier, like let's say if you were to look at this particular DMU and you project this DMU back to the frontier, hypothetical DMU in this front part of the frontier would be using less of the inputs to produce the same level of outputs, right? So in DEA, essentially what I'm doing is I'm trying to find what is that efficiency score, right, where my x's, right? So if you look at this constraint, so this is a vector of constraints. I'm trying to find the efficiency where my uh, my for the focal DMU, the focal DMU's inputs are at least as good, if not better, than the DMU of the frontier, and my outputs are so my inputs are no worse, and my outputs are at least as good as the outputs of the frontier DMUs. That's the whole idea behind this constraint, right? So if you look at this particular optimization, so this is an optimization program, optimization model. Essentially, what I'm doing is I'm trying to get the calculate the minimum value of theta, which is this efficiency score that maximizes my outputs and minimizes my inputs, for the focal DMU compared to the ones on the front. Now, there are two different models of DEA. This is known as the constant returns to scale model, and this is the variable returns to scale. The variable returns to scale in this particular context assumes that you have different returns to scale at different portions of the frontier. So you can see that in this portion of the frontier, this is an increasing returns to scale, whereas this is a decreasing returns to scale. And so this becomes what we call a flexible frontier, right? So Baghdad, Chance, and Cooper proposed the VCC model in 1984, and it basically takes that constant returns and makes it into a more variable returns to scale, problem. So there's nothing fancy about this. This is standard sort of DEA modeling terminology, and we've basically taken that VCC model and applied it to our context to measure value.
I have two questions. One is, how do you account for case mix?
Yeah. So we actually look at hospital level case mix index, and we control for the hospital level case mix index. But we don't do it within DEA. We actually control for it in our second stage model. So we have two stages in our model. The first stage we calculate value, right, based on the mix of inputs and outputs, right, because those are directly under the control of managers or clinicians, right. So since we are talking about a production function, we want to look at those inputs and outputs for which you have direct control over, right? In the second stage, where we actually look at what is impacting value, then we control for heterogeneity among hospitals by controlling for the case mix index, because in many cases, right, unless you're cherry picking patients, your case mix index is somewhat exogenous, right, because it's a function of where the hospital is located.
my second question is there a particular reason why you don't look at process outcomes? So presumably, like in the hospital comparative data set, there are lots of process measures.
Yeah.
That's sort of what you want to measure correctly here in terms of the fund comes in and advises, part of the hospital, we want to make it more efficient. So maybe we want to meet all of these, process outcomes first, even before getting to these health outcomes, which are arguably somewhat disconnected from sort of what you do in that.
I mean, I hear you, but I think, if I'm a manager and if I look at my incentives, right? I mean, it's great to say that I've improved my process measures, right? But at the end of the day, my incentives are based on these outcomes. All of the incentive money, right? Like, for instance, if you talk about many of these value-based programs, right?
The process outcomes are in the value systems.
Well, some of the process outcomes are in this experiential quality measure, not all, but the incentives are are the way Medicare actually pays incentives to these hospitals is based on some of these tangible measures. So when you say process measures, so are you referring to, for instance, if a patient had a heart attack, right? Was the patient given an aspirin when they were admitted? Yeah, so those are.
I think they make this is 25% of the BPP, like patient experience is 25%.
Yeah.
The cost efficiency is another 25%. Safety also is also 25%. So if you think about incentives,
Yeah.
I think it's an easy addition to this paper.
Yeah, and I think some of the, I'll have to ask, in terms of, I'll have to ask Ming Hong, what were the measures he looked at as part of the experiential quality. But again, I hesitate to use process measures when they are not directly related to, either what investors care about, right? And investors, ultimately they care about, how these hospitals are making money. And if the hospital incentives are and payments are linked to these measures, those would be more direct outcomes rather than process.
I'm saying that the process measures are being financially incentivized.
Okay.
Yeah.
These are our summary statistics of our key model variables. So if you look at the first 5 variables, these are the input variables to the DEA model. These are the output variables to the DEA model. So I've shown them as inputs and outputs, and this is going into the first stage, the DEA modeling stage. And then this is so the dependent variable in our second. So based on the DEA, I calculate care value, right, which was the data in my previous slide. So this is for instance, if you look at the data here, it's pretty low. It means that essentially the average care value on a scale of 0 to 1 is only 0.31, right? So it's far from the efficiency frontier. And then, if you look at the second stage, so in the second stage, we have, this is the model that we're going to look at in the second stage, where you take that care value that you computed from the first stage using DEA, and then you regress this on, IT variables and a bunch of other hospital characteristics. But I'll come to that in just a second. Sorry. Yeah. So let me just sort of talk about a little bit more about how we are setting up the research design here. So there are 2 stages to this in our study. The first stage uses DEA to look at care value, to compute care value, right? And in the second stage, we're going to take that the care value that we computed in the first stage, use that as the dependent variable and look at and regress that dependent variable against, specifically, what we care about here are intra-hospital IT and inter-hospital IT, and this measure of information sharing, as well as, I think you asked me, Young, about this question about case mix index. So case mix index, wage index, resident to bed ratio, all of these are the standard hospital controls that we use in the second by a PE firm, right, or where a PE firm made a investment in that hospital, that became part of our treatment group, and then the remaining hospitals were all the control hospitals during our period of analysis. And so once we did the propensity score matching, what we want to look at is in the pre-treatment period, is there any substantive difference between the control sample and the treatment sample across all of these measures, and you can see that the p-values are not statistically significantly different. So this is what we did in the second stage. This is how we modeled the problem. So this is a standard DID specification where we looked at regressing care value on the treatment group. We have a dummy for the post variable, and then an interaction between the post period and the treatment, right? And then we had our controls and the fixed effects for hospitals and the yearly fixed effects as well, right? So these are very, very standard for any DID type of a. So let's take a look at the estimation results here and see what we find, right? So the first test is, let's look at OLS before we use more advanced methods. So in the OLS, right, if you look at this variable of interest, the introspection term of interest, you can see that this negative coefficient shows that, in the post period, after the PE investment has been made on these hospitals, you have a negative impact on care value, negative 0.041, which is statistically significant. And you can also see that the experience quality goes down and the mortality rate goes up, although marginal, right? But it's positive and significant at the 10% level. Right? So very interesting result. This is no different than what some of the prior studies in the PE in healthcare area have shown, which has shown that PE firms actually, once after PE firms have made investments in these hospitals, the quality goes down, right? And you can see that directly based on these two measures. And so what we can find, what we can see is that clearly PE is hurting care value. And if you look at the numerator and denominator, you can see it's doing that by reducing experiential quality, increasing the mortality rate, right, in the wrong direction, right, and it's also reducing labor cost, right. So given that labor cost is a part of your overall operating cost, you can see, that it is basically using labor cost reductions, right, but that is also hurting care quality. So overall, your value actually goes down.
Can I make a comment?
Yeah.
On labor, can you go back to that last slide? In labor here you say is a combination of the number of FTE. So let's say I was wanting to have more efficiency, that I would take some of these physicians and hire more nurse practitioners. And a lot of times these nurse practitioners, if I just need a refill of drugs, can just do just as good of a job than others, but it's going to be a lot less, it's going to be less expensive to do that. So I'm thinking about almost the trade-off. I may have the FTE, if I hire, let's say, 10 more nurse practitioners for one doctor, let's say, does that count as more labor?
It would count as
It's not costs, because I'm thinking the cost could even be lower, but I'm able to meet those waiting lists, that people complain about, patient satisfaction.
Yeah, that's true, except that we do see that if your argument holds that, by hiring more physician assistants instead of physicians, I could clear up some of the waiting times, right?
Right.
So that should improve experiential quality, but you find that even experience and quality is actually going down. So presumably in this case, they're just chopping labor and not using lower cost labor as a substitute for
Right,
higher cost.
right. But okay, just want to make that point. Thank you.
So that, if you look at the IV results for this the baseline model, the IV results also are similar. I don't show it here, but I show it on the next slide. Right? So in this particular, the next part of the problem here is, so clearly in the previous, in this slide, we are showing that the investment, right, hurts care value. That's the first part of that's the first research question, right? So now the second part of the research question is, so what, right? It's not an entirely story, even though we've come up with this really nice measure of healthcare value, and we show that it actually hurts value both from, if you look at both inputs and outputs, right? But that's not that sexy of a story. So what we want to ask next is, how does information, how does IT and specifically information sharing across hospitals, what role does that play? Can that help to mitigate some of these negative impacts of the investment on care value? Right? That is, I think as information systems researchers, to us, it would be of interest to actually say, hey, if we are able to provide the right kinds of interconnectivity across hospitals, so that physicians from one hospital can share patient health data with physicians from the other hospital, that can actually help to improve care value. That's really what we want, and that's why the government is making a big push for common data standards, right? To be so that it's much easier for data from an EPIC electronic health record system to share data with the Cerner EHR system. For those of you who have worked in the healthcare space, you might know that these are different vendors, right, in healthcare, and these vendor systems are notorious for not talking to each other. So this is the specification for looking at the impact of health information sharing.
Yeah, I kind of want to ask a full clarification question. So the info share is time invariant, right? It's 1 year treatment. The time invariant, so it will be omitted in the feedback.
Correct.
And the second my question is, hospital A and hospital B, they were acquired or they were partially owned by a PE company at a given time, and the PE firm have the power to force them to share between hospital A and hospital B.
That's so to your first question, you mentioned it in the footnote that we dropped that. If so, you're saying if a PE firm makes an investments in both hospitals A and B, can they force them to share? Sure, they can. And one of the ways they do that is they could tell. Typically, the way it works is that they could tell the smaller hospital, right, which might be running a different, maybe a homegrown EHR system. They say that, look, we're going to rip it out, right, and we're going to basically take the EHR system from the bigger hospital, assuming that's also the better EHR system, and we're going to, install it in your hospital, and that's how we're going to make them, talk to each other.
That will be great and
Yeah, and I think the AHA, actually, that's a very good thought, because, in recent years, maybe not for the early years in our study, but I know since about 2015 or 2016, hospitals, in the AHA survey, the AHA database, they are required to disclose what is their EHR vendor, right? So I think, to go to your question, if we see that if a PE firm has made an investment in, let's say, 2 different hospitals in the same region, and we see that also one of the hospitals is converting over from EHR vendor to another one, to the same one as the other one, then we can actually, I think that would be of an interesting study. But it's not something that we focused on in this particular case. Yeah.
It's kind of an obvious answer, but did any of these hospitals fail?
not during the period of our study. So if they dropped out, we don't track them in that study.
I think there's an important issue here in the sense that those that receive private equity often have financial distress. Um, when I was in New York, we went to St. Joseph's Hospital, great hospital, good doctors. It's closed. So if many of those that failed, that had injections of private equity, would have otherwise failed. And by not having, you didn't include in the control group for failure because you're including only those that survive.
Yeah.
So it makes it very hard to figure out what's happening because in some sense the true outcome would be what would have happened had they not been rescued by the injection of capital. Many of those would have failed, like St. Joseph Hospital in New York. So maybe, I don't know if this is helpful or not, but might try to having a control group or, some a dummy variable for those that have in fact failed and therefore were excluded from the analysis. So that you do have, so in a sense, your financial data are just flows. And I don't see any debt measures here. But they're important in the story of private equity takeovers because usually these are hospitals, I would think, in financial distress. Not only are they running losses year in, year out, but also they have a lot of debt and they can't service that. So it would be, I think, helpful to have some sort of financial measure in your analysis. Now, the injection of debt confuses me in the sense that my understanding, which could be wrong for sure, is that private equity firms get funding from
Pension funds, for instance.
from many investors. I would call them many investors. And they're putting up the money for the purchase of the hospital, for example. When they exit, and they don't get to redeem or withdraw any of their money, investors, during the phase that they're restructuring. But my understanding is when they exit, they sell and pay off all their creditors, and the profit, basically the percentage gain in value over the cost, is then distributed among the investors, so that portion of debt is extinguished. So the debt you're talking about, that's my understanding. That's the debt that they may be left by the action of the private investors would be new debt incurred. So I would distinguish between the debt they have during the period and then the sale takes place, and it must be a very different picture.
I think good points. I'll have to look into that. I can't give you an offhand answer to that without looking at the data more closely. But I think that's also somewhat of a different research question, right? Because in our study, what we are focusing on are these patient outcome measures, right, of the hospitals, right, and the resources that are utilized. I think what you're saying about the debt, possibly, could be true in terms of how that debt is repackaged when the hospital gets sold. Um, and possibly that could also, I mean, it affects the value of the deal, but I don't know if it affects the value of the healthcare value that we study in this context.
Right, right. I'm still thinking of, would that hospital have gone down?
Yeah.
And thus the healthcare quality would have gone to zero.
Yeah.
And that's a likely issue in many of these cases, as it was in
We could
St.
potentially,
Joseph's.
we
But
could potentially have an indicator for the level of, let's say, if a hospital is a distressed hospital,
yes,
right, before the
yeah.
PE deal, based on some measure of financial distress, and
Yeah.
control for that in
Yeah,
our
I think
matching
you
between the control and the
definitely
fee.
could, and it would be a flow variable,
Mhm.
because it's
Yeah.
their losses.
Yeah.
And so it would fit in. And I think it would be helpful, but I don't know. I'm just guessing.
Yeah. No, and that's something that we could definitely, I think
Yeah,
we could
definitely.
incorporate into our model. So let me, proceed in the interest of time. So this is the model for information sharing, where we look at the impact of information sharing, and the key variable that we are interested in is the three-way interaction. It's really a two-way interaction of treatment times information sharing in the post-P. Right? So for information sharing, we collected data on information sharing from the AHA database, and we looked at 5 kinds of categories of patient data that were shared: demographics, clinical care records, lab results, medication history, and radiology reports. Right? Because these are all very critical components of any patient encounter and patient care. Right? So as I gave you an example before, if I had access to somebody's CT scan through the radiology reports, I may not need to run another CT, which is not only inconvenient, but it also adds another $1,500 to the poor patient's bill, right? And then I look at information sharing both within the same health system and outside the health system. So if, let's say in Austin, St. David's is a large healthcare system. It's actually owned by HCA. So all hospitals within St. David's are considered to be part of the same health system. So I differentiate between information sharing within that health system, right? So within the St. David's umbrella, right? And versus outside. So suppose St. David's is sharing information with Baylor, Scott, and White. That's considered outside it's called inter health system sharing. And then similarly, I look at, so this is with hospitals and this is with ambulatory care providers. And why am I differentiating? You'll actually see based on the empirical results why the story actually changes quite a bit when you look at information sharing, the heterogeneity of the information sharing with different kinds of providers. Right? So in the survey, information sharing is, it's calculated as the percentage of yes responses at the hospital year level for each of these different categories. Right? So we aggregated them. So here, I'm jumping straight into the 2LSRS estimation results. So we used an IV here, where the IV is the average level of health information sharing, because health information sharing is an endogenous variable. We looked at the average health information sharing of peer hospitals, neighboring hospitals in the same hospital referral region. Why is that important? Because that is likely to be correlated with the level of health information sharing of the focal hospital, but it doesn't directly affect the care value or the care quality of the focal hospital. Right? So let's look at these results and see what they tell us. So we find that compared to the first result, the information sharing among the treatment hospitals now is marginally positive, right? Positive and significant at the 10% level. And look at these. The operating cost and the capital costs go down, right? There's still, there's a cost pressure, right, where they're reducing capital costs and operating costs. But interestingly enough, you see that the readmission rate has also gone down, hospital A to hospital B, right? And we find that with respect to cost, the results are still the same, but guess what? You can see that quality is not affected, right? Labor is still negative and significant. Care value, interestingly, has gone up. But the interesting part of the second analysis is where hospitals are sharing with ambulatory care providers, right? Which means that these ambulatory care providers might be your primary care physician, your PCPs, right? And so what we find here is that when you are sharing information with ambulatory care providers, your care value goes up marginally, right? Operating costs and labor costs come down, but your readmission rate actually goes way down. Why is that important? If let's say I'm the patient, Niam is my primary care physician, and Robert represents the hospital, right? The reason I'm going to my primary care physician is because he knows exactly he knows my history. He knows my allergies, he knows my medications, he knows the kind of treatments I've been on, and it's important for that information to be passed on to him. Because he's flying blind, he's in the hospital. I don't see him very regularly. I only go to the hospital when I absolutely must go, right? So it's important for those ambulatory providers to talk to the hospital providers. And that's what this is measuring, the information sharing between hospitals and ambulatory care providers. Where if Niam says that Indranil has an allergy to this particular medication, or Indranil's records show that he has a history or a family history of heart disease or whatever else, treat him in this particular manner versus not in that manner, right? Or here is the most recent CT scan result. You can use it. You don't need to redo it. So all of these, these types of information sharing actually improves my care value, and it might also impact my propensity or likelihood of landing up in the ER again or landing up in the hospital again, right, which might contribute, to a lower readmission rate. So it brings down my future readmission rate. So what we do is we actually see that the mechanisms for care value are slightly different. Hospital to hospital information sharing primarily reduces labor costs, right? So it helps to cut down on duplicate tests. It helps to cut down on perhaps the need to do even duplicate procedures, right? But hospital to ambulatory provider information sharing actually improves both cost efficiency by reducing labor costs, and it improves patient outcomes based on the lower readmission rate. So if you look at the mechanism, right, it's important to tease out the mechanism. Not important just to say that information sharing is good and information sharing has a positive impact on that relationship between PE and value, but how different kinds of information sharing can play a role. Yeah.
Also, I think the reason that it's much more effective is that there's a lot of research that shows after hospitalization, you visit your primary care physician, especially if he or she has access to your hospital records.
Yeah.
They can see a lot of problems
Absolutely.
and prevents you from going back.
Going back, yeah. So it's kind of the reverse where the information is being shared from him to you. Yeah.
Whereas that hospital to hospital, especially if you think about it, the distance between hospitalizations is usually so long
Yeah.
that even if we share that information, it's not
Might be
directly
outdated.
relevant.
Yeah. Yeah.
I don't know much about this setting in the sense, but there must be costs, also sharing, I guess. And there must be incentives not to share.
You raise a very good point. Actually, the only cost here is how you make the two EHR systems compatible, right? So there is an IT cost, right? So that's why the government has actually mandated that hospitals adopt this data standard for information sharing called FHIR, and they're pushing hospitals to adopt it. But in the meantime, he's done a ton of work in health information exchanges. If the hospitals don't have similar EHR systems or the same data standard, they can exchange records through a third party, which is this HIV.
But in case you actually can do this, but it can still be beneficial not to share or because you want to do double. You want to generate more revenue.
Absolutely. So there's always the effect of competition, right? Healthcare providers are, they want to protect their term, right? They want to reduce the likelihood of like when I say best patients, I'm talking about the patients who bring in the most revenue, right? From being poached by competing health systems. And for a long time, that was actually one reason why they were not, sharing health information. But actually, part of Obamacare was actually to break down those silos and to actually get them to do it.
So I don't want to break down your flow here, but I wanted to ask you also about.
Good.
Yeah. What about sort of this set of technologies that is based on blockchain that actually takes their own data and for how likely would that ever be in the world?
I think it is coming, right? As part of you don't even need blockchain actually to do that. You could potentially put it all on a wearable device, right? And your Apple Watch or your iPhone with the right app could actually you could store your ECGs on that.
Isn't Apple your
Well, I could put it on the iCloud, and I could, have it down. The other physician at a different hospital could download it from there if the systems are compatible. Right? So what I'm saying is that blockchain may be one instance of doing it, but it's not the only one, right? And
it's not the only one, but it would break with its backbone.
yeah. And with anything else, Ola, I think hospitals are also tremendously risk averse, right? With everything from HIPAA and security of the data, right? From leaving their organizational boundaries. So to answer your question, can it be done? Yes, I'm sure it can be, but practically, I don't see. I haven't seen a large.
Well, they're doing it in Estonia already, right? So in Estonia, they already have a blockchain-based system precisely because it's more secure, precisely because the healthcare data in Estonia should be on a very secure infrastructure because they are afraid of getting hacked by Russia, right? So.
Yeah,
I wouldn't want to.
It might be a nationalized health system.
No, it's not. Yeah, exactly. In Estonia, they were thinking not have it all figured out.
But I think to answer your question, definitely, I think that is a possibility. But again, in the period of the time that we were looking at.
No, I understand. In the next 20 years or something like that.
Yeah, but it's already happening in Europe.
Yeah,
so
I think it needs some
But the idea of consumer-centric healthcare, where the consumer owns the data, right, is it's already happening, and there are new mandates and regulations like the information blocking rule, which prevents EHR vendors from blocking the sharing of information records. Those
yes, in a sense, you do have redundancy probably, so the patient would be able to own their own data, but of course you wouldn't erase previous.
Correct. Yeah. So the biggest challenge I think to that is somewhat of a regulatory issue because what is considered part of your legal health record is still an open question. If I'm the patient and I'm owning my health record, if there's something that I don't want my physician to see, like let's say I go to another physician, and if I have a substance abuse problem and I want to remove certain records, opioids for instance, right? Then does the physician rely on my record or my version of the record, or do they rely hospital to hospital information record, that's still something that is not very fit.
I think
I
I think socialized medicine. So if you think about Europe, when you have socialized medicine, it's much easier to implement a lot of this. And
yeah.
now, so that's the problem with the
But
United
initially,
States in terms of all these other vendors and hospitals.
yeah. I mean, what Ola said, with blockchain, of course, if the record is altered, uh, the other the other players would be able to see that the record has been altered. So probably blockchain might actually provide the higher level of security to make that happen. I
Mm-hmm.
don't know. I mean, I haven't studied it in my whole
It
record.
would be one record for sure.
Yeah,
And you would be able to define levels of sharing levels. But as a patient,
yeah,
I would allow different levels of I could.
yeah, yeah.
But of course, it would be, and you would only give out the key when
Awesome.
you need it.
Yeah. So I'm going to wrap up my presentation here. So we actually did like just we looked at this organization, LifePoint Health, which was bought out by a PE firm. Apollo Global Management is one of the largest PE firms, and they actually did make some substantial investments in their health IT infrastructure following the PE investment, to exactly, you know, um, address some of the IT deficiencies and be able to improve both quality and reduce cost using, a health catalyst and Google Cloud in this. So what are the key takeaways? So what is my main message? PE investments do result in an overall decrease in healthcare value. That's what we find, which is consistent with the literature, right? So we're not saying anything different than what other medical studies have shown, that it does result in squeezing the costs and also hurting quality. We do find it. But the interesting aspect of our story is that when you look at, does IT enable information sharing moderate this relationship? We do find yes. The answer is yes, by substituting labor while reducing data storage. That's the mechanism, right? So the story is nuanced because it shows that while PE does hurt care value, the right types of information sharing can actually make a positive impact or positively moderate the relationship. And we do find that different kinds of information sharing influence care value in different ways. And really, the one we should focus on is the information sharing between the ambulatory provider and the hospital, not just the hospital, which has been the focus of previous studies. Right? And so, what are the policy implications? We feel that there is a real need for policymakers to look at a more holistic approach when evaluating the role of PE in healthcare, look at value as a whole rather than these individual measures, right? And also prioritize IT investments, prioritize those health IT investments so that it makes it easier to share information across organizations. That is the key message. So with that, I'm sorry for running late, but thank you for your help.
Thank you very much.
My pleasure.
Michael, nice to meet you. I think we were on the PNC today.
Is that right? Was it a Zoom committee?
Yeah, that was during.
Yes, that's right. I remember now.
Thank you. Thank you.
Yeah, I'm James. I'm really strong.
Yeah.
How are you?
Okay. Is that, are you planning to come?
We have lunch.
Yes, I was asking the call when they was drafting. Yeah, I think
Right, the gas, right? I'll come back to the computer. Say fine.
yeah, I think we went to the bathroom.
Yeah, I was really shocked.
More than one.
So I was going to the.
I don't know, but I think so. I think so. He's coming back. Okay. Yeah, it's a problem.